Hello, everybody. Welcome to the webinar. I've got a question already before we get started. This webinar is going to be good for staff and management of a company that's an eye care company. We are certainly going to be focused on giving advice and instruction to eye care business owners, but if you would like to have staff attend, one of the philosophies of GPN Technologies is to make the entire practice better, so we're really happy for anybody to attend. This is the kickoff of our fourth webinar in the group called Next Steps. I'd like to just, as a courtesy, remind everybody in attendance that everybody that arrives into this session is going to be in listen-only mode. That means you'll be automatically muted, and we will not be opening microphones during today's session, so we won't have to worry about any background noise from your location. Don't worry about whether or not your microphone's on. You will not be heard. Any of the questions that you have for us should be typed through the Q&A or chat system at the bottom of your screen. We'll be filtering for relevant questions, and we'll try to answer them either during or toward the end of the session. But we may be batching some of the questions to make sure we can get through as many of them as possible. The Next Steps webinar series by GPN Technologies, today sponsored by iDoc, is providing a real practical roadmap to getting back to business, and it's the fourth of a number of sessions that GPN Technologies has been hosting. This session is called Practice Culture Shift. And the goal today is to focus on communications with both your staff and your patients. And we have a really robust panel of experts. I'm Scott Jentz. I'm a doctor of optometry, and I serve as a senior executive coach at GPN Technologies as part of my executive business coaching service called Sandbox. And it's my pleasure to introduce our panel of experts. There are four. And each of you should say hello when you are introduced. First, Dr. Lorie Lippiatt is from Salem, Ohio, and amongst the many things Lorie does, she's currently on the executive board of the Optical Women's Association.
Hi, Scott, everyone. Good to be here.
Thanks, Lorie. Thanks for being here. And Dr. Brian Kane is from Cleveland, Ohio, and he's active in practice and many community activities and speaks for a wide variety of eye care companies. Welcome, Dr. Kane.
Thank you. Glad to be here.
Next, we have Dr. Jen Stewart. She's from Norwalk, Connecticut. She's a partner at Norwalk Eye Care and has founded a sports performance vision training center. She's also a frequent lecturer and contributing writer, and I'd like to welcome you, Dr. Stewart.
Thank you. I'm glad to be here.
And last but of course not least is Dr. Walter Choate from Nashville, Tennessee. He's CEO of a large group private practice and has lectured extensively in the eye care space. Welcome to you. Well, it's wonderful to have everybody here and for you to share your time and expertise with us today. We've had really wonderful feedback on the GPN Technologies webinar series called Next Steps. And I think the reason is that we're trying to bring real-time information from real experts who are doing what you are doing in the field. Some of them are doing things you haven't tried. Some of them maybe aren't quite where you are, and we're having a great back and forth, and I want to make sure I can facilitate that today. So again, type any questions you have in the Q&A section, and the GPN staff and I will monitor those, batch them, and answer them as best we can. Our goal is to increase the amount of time that all these doctors have a chance to talk with you, so I'm going to get out of the way. Our first areas of discussion will be patient communications. Then we will be talking about staff and patient protocols, and finally getting back with the right team. In the area of patient communications, I'd like to start with you, Jen. You're in a very unique area there in Connecticut with lots of things going on with infections in your county. You know, as you talk to patients, what are you doing to communicate this ongoing delay you have to open?
So we are in one of the hot spots. We are around 20,000 cases in Connecticut, over 10,000 in our county. But good news, as of today, we seem to be plateauing and slowing, so that's great news for us. You know, we're a little bit different than the other panelists in that we don't have a start date yet, but we're continuing to keep our patients updated that we will be back. We will be back to routine care. We're continuing to provide telemedicine and emergency care, but every week we're letting them know that, you know, we're here for you, we're available, but we don't have a start date yet.
How are you communicating with them?
So we're sending out newsletters once a week through Solution Reach, and we're also calling patients who have been scheduled for, you know, we're already starting for May 4th. We had anticipated being open May 4th, but that's not going to happen. So we're personally calling each patient who is scheduled for next week and offering them the chance to move to June, because we're not quite sure when we'll be back, or we're giving them a chance to go on a waiting list and be called first when we do open.
How about the rest of you experts? Let's talk a little bit about how you're communicating about your state of openness right now.
Well, we have used for patient care. We've used other platforms, but we're using them right now pretty solidly to communicate changes in our plans. I'm pushing out regular communications to my staff via email and text. We're using Facebook a lot to communicate with our patients. And that's pretty much it. So we just tried to let them know we're available.
We've implemented Weave in our practice in the past few months. So we're using Weave and iCare Pro, who runs our website. The Weave we use as communication device with texting and emailing our patients. Initially, when we first had to push exams back, we pushed them back only 2 weeks and realized we really should have pushed it back a month. And when we did that at first, and still to this day, when we're rescheduling those patients, we call them personally, have a conversation with them, explain that to them. But then as time goes by, we're letting them know we're still here. They can order contacts through us. Depending on their prescription, we can get them glasses, that sort of thing. And then with iCare Pro, I just send a letter to my consultant I deal with every month, and he updates our hours for our practice, things that are changing, what's available, and he sends out those notices through social media every week to our patients so they're informed. And that includes the Facebook like Walt's doing. I think our website, and I don't know if you can do anything with Google, but Google he updates the hours, I think. So.
And we're pretty much the same. We're using all of the above. We use iCare Pro as well. And for patient care, we've been communicating regularly. We send an update. We are sending weekly update email blasts to our patients with every safety implementation that we're making in the practice, which has proven to be very helpful as we communicate with bringing them back into the practice for essential care.
I just broke my own rule. I didn't unmute myself when I spoke. Lorie, don't you also make real-time or regular updates to your patient-facing website?
We are, and you know, it's funny because we actually are seeing more essential care patients as of this week, and patients are coming in telling us that we put a what to expect when you visit our office button on the front page of our website, COVID-19, what to expect. And we are asking them when we confirm their appointment to go review that. So that's helped a lot with patients arriving with face masks on, being prepared to be seen, knowing the safety measures that we've taken, and it's answered and alleviated a lot of their fears and concerns.
Brian, talk a little bit about how you want your patients to arrive, with masks, without masks. What kind of messaging do you want to give your patients about the safety measures that need to be in place for you to be open and moving forward?
Well, I think Lorie touched on it already. With Weave, we're able to text and email patients customized links. So first of all, we're letting them know that a week out, we want them to complete their medical form as well as their registration form online, which goes directly to a HIPAA compliant email so we can update their records, and they don't have to fill any paperwork out before they come in. So we're trying to eliminate as much time as they are in the office. We're planning on having the front door open. Patients realize that. They realize that they're going to have to sanitize their hands before they come in. We also want to make sure they understand they have to have a mask on. And we're asking patients and requesting patients to wear their own mask due to supply and demand for us to be able to have enough for all of our patients. Certainly we're going to have some on hand to help if we need it, but we really want to convince the patients to take responsibility on their own and bring their own masks in. The way we're communicating that is we're sending out a text and email a week before indicating that, and then the day of we're sending another text and email that allows the patient to answer the COVID-19 questionnaire, what the CDC recommended. If a patient answers yes on one of those, they're instructed to reschedule. But if they answer no on all the questions, then they obviously can come in and have an appointment. Patients also are being let know that we're going to be checking their temperature upon an entry into the building, and we'll have barriers and so forth. So I think it's a great idea to have it on your website. With what Lorie's doing, it's excellent because it allows those patients to go and look and browse on their own time.
Walter, how about at your practice?
That's our front page of the website, and what I basically did was have what you can expect when you arrive at the office, and when you push that button, it takes you to the next page. What just happened? Well, technical issue. But then we have created a bunch of bullet points on the website that they can see about what to expect when they see our office this time. We've taken most of our chairs out. There's only a handful of chairs in the waiting room area. You won't see magazines and brochures or anything on the counters. We've installed medical grade air purifiers throughout the office, 2 large ones in the main area. They filter down to 0.1 microns, so they filter bacteria and viruses continuously and keep the air moving. We're going to have buckets with warm soapy water for frames that have been tried on to a patient. We can just throw those frames into the warm water and soapy water and let them clean, and then we can rinse them, put them back, let them air dry. We're just trying to communicate basically that we're going to probably have the cleanest place they can be in town.
Jen, you're in that position where you're not yet open for patient care, so you represent a fair number of attendees. What is your preparedness looking like in terms of getting access to some of the protective equipment that maybe some others have? I mean, Brian just alluded to having limits and not being able to give every patient a mask. How are you preparing, and what resources are you using to try to find equipment and set your practice up?
So in Connecticut, we're mandated right now to be in public for the last week and a half. So anyone that is out and cannot social distance within 6 feet must be wearing a mask. So our hope is that when we return to patient care, weeks or minus, that patients wearing masks, that'll just be something they're so used to versus, the states who are opening now, and that's different. So we're hoping that becomes kind of a non-conversation, that patients will be expected that they've been carrying around masks for weeks. So we're going to continue to communicate that. But as you know, every day has been over the last few weeks. So we're, continuing to accumulate masks, gloves, but we don't know what the landscape's going to look like at the end of May. I'm optimistic that hopefully we'll be back to normal. That's a little optimistic, but I feel very fortunate that I have these great panelists and all of the doctors who are returning to care this week and next week that we can learn from. So I'll be learning and listening and talking to all of my colleagues in states that are opening for business and getting their best practices as well.
So a couple quick questions. Dr. Choate, simple question. Would you be willing to say who is providing your website, your practice website you showed?
Einstein Medical. Einstein
Okay.
Industries out of San Diego.
Okay. There's a question about whether or not plexiglass is a necessary front desk feature. I know, Lori, you put yours up. How do you feel about that now that you've been seeing more patients?
I feel really good about it. The sneeze barriers certainly aren't the only answer. They're only a tool or part of the answer. But for a couple of reasons, patients have commented on it, but my staff feel, even though they're still wearing the shields and the mask, they still feel safer with the shield. So it's worked very well for us.
Could any of you speak to, with experience-based, unfortunately, maybe this takes Jen and me out of the equation, patients are either going to choose not to wear a mask, or during the exam process, due to phoropter fogging or wanting to try on frames, are going to ask to remove their mask. Can you speak to how you may address that or have addressed that?
Late at night, emailing Brian. It happened last night.
Yes.
Please.
Yeah.
We've had confirming appointments for next week. We had one guy say, "There's no way I'm wearing a mask."
Yep.
So to his remark, we said, "Well, we may need to reschedule you.
Exactly.
You're going to need to wear a mask." But now you bring up a point. I haven't seen patients yet. We start next week. So what are you doing in the optical for frame solution, guys?
Well, Lori, we both thought of the same thing, but I think she had to step on me. So why don't you explain what you did?
Well, it's funny because yesterday, we started back seeing essential care. So some of the essential care that we're seeing are people now with broken glasses that need them replaced. So we're now doing refractions, and of course they need glasses. So as prepared as we've been, we didn't really consider how maybe patients would feel with 60% of their face covered in a mask trying on expensive frames until yesterday. And quite honestly, that isn't a real positive thing. So Brian and I both were kind of last night, hey, what are you doing about this? And I talked to my optician. We've decided that there's no other way than to have her continue to wear her shield. Patients continue to be behind. We're adding a plexiglass barrier on the optical dispensing tables, and we hadn't planned on doing that until yesterday. So I got those ordered last night, and they'll be here Monday.
How does the barrier work when your staff usually puts frames on the patients?
So the opticians are still wearing the shields. We talked about the shields. The barrier is going to be for a very short amount of time while the patient has frames that they've narrowed down to remove the mask from their face so they can see what the frame looks like. Then they'll go ahead and put the mask back on for the rest of the dispensing process. So again, for a short period of time, I don't know of any, especially the female patients, they want to see their face with their new frames. So we're working through it. Let's leave it at that.
I think that's, go ahead.
What I was going to say is I really don't know if you're going to use the shields and an N95 mask. I don't really know that you need to be that concerned about it because the counter's going to be wiped down after the patient leaves, the chairs, and the frame's disinfected. So it very well may be the extra barrier for that short period of time when the patient's uncovered. It really is not going to endanger the staff.
I can understand where you're coming from on that, Walt. What I would tell you is the more we do, the more comfortable our team feels about it, as well as our patients. And I want to send that message to them. And we're also, to add to this, why take their mask off, you have the shield in place. Once the mask goes back on, you can remove that shield and move it out of the way. But on top of it, we're asking our opticians to pre-adjust the glasses. And when those glasses go to the lab, we have notes on there to please be delicate. These are being shipped directly to the patient. We want it to hold its adjustment. And we ship those directly to the patient, or if they come to pick them up, we're leaving them outside in the bag with their name on it for pickup that day that they call that they're coming in. So there's a couple of things you can do there, but I think the more we can do it just at the beginning, and I'm sure we're going to be much more lax as time goes by and as our pedal pulls back, just like it is in Ohio compared to up there in Connecticut. Connecticut's in a much different situation, but here in Ohio, we're in a better situation at this point, thankfully. So we're able to back it off. Now, one other thing about the mask I didn't get a chance to mention is our governor has made it easy for us. He's basically said no shirts, no shoes, no service. He says no mask, no work, no service, stay home. So basically he's telling everybody, don't dare come out and try to do something without having your mask on. So it makes it easier for us as professionals to make sure we're doing our job.
Yeah, and to be fair, that just happened yesterday. So we were dealing with patients not coming in without masks until yesterday. Well, until today, really. And today, every single patient, every 100% walked in with a mask. So Jen, you had mentioned how that was, part of lifestyle in Connecticut, and you were hoping. I can tell you it was a 24-hour change here, and everyone's wearing a mask.
You guys write our governors and tell them they need to make the announcement. It made a huge difference. I agree.
Go ahead, Walter.
Let me say something about the plexiglass screens.
Walter, come a little closer to your microphone. Thank you.
Let me just say, I did a little bit of research, and you can buy small plexiglass screens that are on stands, and they're designed for nail parlors and those kinds of places, but they're smaller and portable, so you move them in and out. And that's basically what we're going to talk about doing. I'm not going to put a permanent anything up in front of a permanent barrier that we can't move around. So on my front desk, we'll have two that are about 36 inches wide, and probably about the same height, and they can slide back and forth because we've got a large semicircular area. But the attendees can find those online if you just Google plexiglass, plexiglass screens.
So we're going to stay in the area of patient communication. A couple of things that came up, we're just going to hit them quick because they are related to reopening. And we've been good fortune to get some advice from people like Dr. Lippiatt in the past around sufficient frame sterilization. Actually, soap and water is great. Soap is ultimately the way to break through the outer layer of most viruses. It can destroy the virus immediately. So that's why washing hands with soap and water has been so important. That, of course, also takes care of frames so long as those frames can be exposed to the soaps you use. And if you don't have access to cleaning materials, anything that's got 70% alcohol or higher is sufficient. There are a lot of questions around PPE. I'm sorry, we're not going to be able to answer all of them right now, but I think that the point that is being made, and I want to get back to, is what we're doing in most of these cases is trying to convey to the patients the state of our readiness and a state of safety. So one of the things I want to get back to is talking about the schedule. Jen, you talked a little bit about trying to get your patients to, to move a little bit. How are you managing the rescheduling of patients right now?
So we're moving them to June at the earliest, and even during July, as we're not quite sure if May is actually going to happen. And we're offering them, when they feel comfortable coming back in. I think people have been mixed. We've had about 50-50, about half of them want to come in, and I feel like we keep moving those same patients. But half say, thank you, I have kids at home. I don't know that I'll be able to get in. And so they're moving to July or August, putting themselves on a wait list.
Are you prioritizing special needs patients, those being with chronic conditions that have issues, or any other prioritizations? And then why don't you answer that, and then we'll follow to the rest of you on that.
We haven't, just because we don't know what that's going to look like, and we're so far removed from opening. So we didn't want to start to make that determination because we don't know when we'll be back in, or how that's going to look, or how the environment's going to look. Every day and every week's been so different. We'll probably make that decision as we get closer and see, what that list of patients that's on that has made that decision that they want to come in ASAP. Who are they? What are their ages? What are their conditions? And kind of decide how we're going to tackle that.
Doctors, talk about prioritizing schedule in patients as they come back. The difference between an AMD patient who's at risk of wet degeneration and a -6 myope who's got broken glasses. I mean, these are almost impossible, justifiable decisions on who gets priority. But how are you thinking about seeing patients, say, somewhere in May or in June as your schedule comes back?
It's an interesting question, Scott, because I spent one of the things in our schedule that we had a hard time figuring out how we were going to manage is we have one column of comprehensive exams, and then we have another column that are some sort of medical care or contact lens care, whatever. And unfortunately, I don't know a better way to do it. I've been going through all of the medical column and prioritizing which of those patients are going to need care sooner than others. And Lori made a suggestion to me. I think it's a very good one. If you go in and look at some of your glaucoma patients and they've got little or no visual field loss, pressures are well controlled, they're probably good to wait until August, September on a follow-up visit. Past that point, for next week, our first week back, we're going to see comprehensive exams only, and any medical evaluations will be urgent type of calls that we get. The following week, we're going to have two exams per hour, so a total of 16 patients next week. The following week, we're going to add one medically related testing type of visit. And then hopefully the third week we'll be up and running. We'll just have to see how it goes. Right now, we've been pleasantly surprised. The patients are excited and very thankful we're back in business. They're anxious to get back and see the staff and be a part of the practice. The first 2 days next week, we're full. The rest of the week, we're about half full right now. But at least we're seeing the calls coming back in again.
Hey, Walt, with your schedule that you started, I think one of the questions would be a good one is, like, I'm assuming you're maybe seeing a patient every half hour for routine care. How are you scheduling in your emergencies, and how are you handling those patients that might need the medical care? That's another person in addition being in your office at the same time as another patient, and are they in a different separate room, that type of thing?
Well, we're basing it on the size of the square footage in the office. We've got about 3,600 square feet, 10 staff people. We're not going to have the full staff next week. We typically don't have but a handful of days in the week that we'll have 3 or 4 emergent types of calls. We are not doing any routine care next week. The patient has to have vision complaints or medical eye complaints, or they've got a pre-existing, that's basically it. They've got to have vision complaints and medical eye complaints for us to see them. Following week, we're going to keep the exams to that same level. That means that if somebody has no complaints whatsoever, it's just time for an exam, we're not going to see them. So they have to have specific needs for me to see them. That's what we're calling essential care. Probably week 3 will be moving a little more frequently, moving to a more bigger schedule. To your point, they will be added in the regular medical column at the least obtrusive place. I mean, our staff is pretty good at picking those spots because we know so many of our patients can be very complex.
Okay, thank you.
Lorie, is there a standard by which you would schedule a family that wants to come in together, that family being more than one person at a time? Are you still staggering them? Are you allowing them to be there together?
Great question. So we have been seeing emergency patients. We are expanding now to essential patient care. To Walt's point, they have to have a medical or vision related problem. The key word is, a condition under which we're seeing them to provide care for. So mostly in our practice, especially with Dr. Abraham being a pediatric optometrist, when families come in, it's more routine care. We're not providing that care right now. So we are making no exceptions to any rule right now. We are scheduling one patient every 30 minutes, regardless of reason or problem. So one every 30 minutes. We've been doing this now for a little while. I don't feel at this point it's been not enough time to where I feel comfortable advancing that schedule. Everything is taking longer. I'm surprised at how much longer everything's taking. Staff is feeling good with this schedule. I want my staff to feel good where they're at before I start pressing. And it's not time to press yet. Patients feel good. We're doing the right things, and I'm comfortable where we're at. So we're not doing that.
Okay, so I'd like to have the panel shift their thoughts toward communications with staff, right? And creating the right culture in your practice is making everybody comfortable. We've had some, questions come in around staffing and the use of PPE. How do you manage walk-ins? How do you envision dealing with somebody who wants to be in the building and you've already decided what your patient load should be? You've scheduled this sort of cautious way. How do, the staff are the ones facing these patients, and you don't want to be turning anybody away and creating an offensive situation. But could you guys talk a little bit about communications? Because our staffs are going to be the front of that. So let's shift the staff and let's start with how you teach your staff to talk to patients.
We kind of had that discussion already. We've been trying to ramp up, get ready for next week with opening. And we would just simply ask that person to please just go out to their car for a moment, phone call into the office, and let's have a discussion and find out what the issue really is. And whether if we cannot see them today, we'll get them on the schedule to see them at another time. They may not have come prepared. They didn't fill out their paperwork. If they have the ability in the car to fill out their paperwork and so forth, and we have the ability to see them because maybe we have an opening due for an eye exam, we'll see them. Otherwise, we're going to ask them politely, just if you could step outside, give us a call, and we'll go through the paperwork. We're just hoping they'll be respectful of that. And I'm sure you're going to have some patients that are going to be angry. And you just have to be super sweet and just let them know that this is in the best interest of you and our patients. So
our plan is that we are going to have somebody sitting out in front of the office before they open, before they're entering our office. We're going to have a technician with a bottle of Purell and a thermometer, and also just kind of the triage before they enter the office. So
is your door directly to the outdoors?
This will be once you enter our building. We're in a kind of floor of a building, so they will be kind of sitting in front of our door. This is our plan. But you don't get a lot of walk-ins based on our location, so we're not really concerned that we're going to have this huge patient flow. We've always scheduled optical appointments from day one. So we don't really people walking in to look at glasses. We do here and there, but we usually let them know that everything's by appointment. So that won't be a huge culture shift in our office. When we call to patient know that their glasses are ready, we've always scheduled them with an optician. The opticians have their own schedule. When they're, if they need an adjustment, same thing. They've always been pre-scheduled, just and make sure that there is not available. So I think putting those policies into place early has had our patients conditioned that, yes, we're here, but everything's by appointment. But we're hoping by stationing an extra outside the door that we'll do the same thing as Brian, oh, you're here for this. Well, can you wait in your car? We'll just send you, a text message or give you a call when we're available, and trying to put it on the side of not on that it's our policy, but we're doing this to keep you safe. And we're trying to limit the number of patients for your safety and the safety of our staff, but spinning it to make sure that the patients know that the reason we're doing this is in their best interest, and that everything we're doing is to keep our patients and our staff safe. So, making sure they understand it's all in the phrasing and not, no, you can't come in, you have to go wait in your car, kind of spinning it. We will script that ahead of time so that our staff is well versed. But yes, have kind of a patient care coordinator out front, just check why here, and that's, that way they're not congregating anywhere. So that's our
Walter,
plan.
Yep. Walter, you're getting ready to see patients. How are you kind of coaching up the staff to get ready to have these conversations with patients?
Well, specific to the prior question, my practice is always, it's about 48% medical. So we're in a building that with other types of businesses. So we don't have a lot of walk-in. But our colleagues that are in more retail situation where they have walk-in traffic, which is very profitable and very good, I see that as a problem for those guys, because we're not going to allow people in the optical to browse the frames. We've always had the patient sit down and have our trained opticians bring the frames to them. As far as the staff, we've been regularly communicating via email. I've been picking up the phone and calling them just to see how they're doing and kind of measuring where they are with the fear factor and the same. And I brought two of my staff front desk people back yesterday, and as soon as our e-blast from for patient care went out, phones were ringing off the wall yesterday. So there is going to be, for those of you who are not open, I think there's going to be some pent-up demand, and I think we're going to be back to reasonably good business pretty soon.
Lori, anything to add?
No, I think they covered it pretty well. We're in the same position, not a lot of walk-in traffic. We schedule everything. So that has really helped us during this crisis. Our patients expect to be seen by appointment, but like Brian said, we are willing to work with patients to accommodate their needs depending on what that is.
For anybody who hasn't seen Dr. Lippiatt's summary of her practice setup and flow, that was our webinar about a week or two ago. Can't remember when. Please visit GPN's iThrive website. But while we have you, Lori, let's kind of do a mini course of what you did then, particularly around staff. We've had some folks ask about the mask you showed that haven't seen it before. Let's talk about staff specifically, right? How are we getting enough PPE for them? What are your standards? How are you looking up in the oculars of a slit lamp with a mask on and not fogging up? What can you give us in terms of practical experience now 6+ weeks in seeing patients through this process?
Right. And I guess the number one thing is get in your practice and start practicing with all of this stuff and your staff as well. It's different touching a frame with gloves on. It's different for you as a doctor if you're using an EHR where you have to type. It's different typing with gloves on. So it's different doing BIO with gloves on. Supply. So start working now on supplies. Supplies are limited. There are supplies out there. There's a lot of us and there's other ways to figure out how to get the supplies. You're going to need more than you think. We started doing a little check-in tally from the beginning of just to kind of gauge, because I had no idea, are we going to use 25 masks a week? Are we going to use how many pairs of gloves? I'm changing gloves between every single patient. So let's see, today I've seen 10 patients. I've used 20 pairs of gloves. So today. So
10 pairs.
What's that?
10 pairs, 20 gloves.
10 pairs, 20 gloves. There's 100 in a box. But I'm just saying you're going to go through this stuff quicker than you think. So maybe start getting an idea of how much you're going to be using. So we landed on gloves for staff, gloves, masks with eyewear for added protection at all times in the building. So surgical, 3-ply surgical masks with these units for all patients. They're not really having trouble looking behind any of the testing equipment. We use all automated testing equipment. Obviously, this doesn't work for me behind a slit lamp, so I carry these glasses in my scrub pockets, wear this in with a patient until I do the slit lamp, put these on behind the slit lamp. I have slit lamp barriers on all of the slit lamps. So gloves for the doctors. We're wearing N95 masks. Obviously, one tip I will say about these, if you're a female, do not wear makeup, do not even wear moisturizer, plain bare face with these N95s. I will say that I feel very safe with an N90, much safer with an N95 than a surgical mask. That's been an upgrade for me, but we had trouble getting them the first few weeks. So that's it.
That's great. Can I ask the other doctors how you're feeling about hand washing, which is minimum essential, and gloves? And we don't have to have everyone thinking the same way here. We're getting a lot of questions, and I'd like you to just kind of give your opinions. The three of you that haven't spoken on that topic, let's talk about you and your staff, hand washing versus gloves. Give us your thoughts.
So we saw patients in March, but we shut down, and I have not seen patients since. But the last week that we were there, I was hand washing and only gloves if I touched the patient. So, I felt with hand washing. I mean, that was in March, but I washed my hands multiple times throughout the exam. We did have our opticians wearing gloves when they were working with glasses, and then tossing those gloves after. I don't know what that'll look like when we go back, but I felt confident washing hands while seeing patients.
I agree with that.
Right?
If you're not interacting with the patient, wash the hands. But if I'm going to touch the patient, or my team member is going to be touching the patient's skin, they should be wearing gloves. And that's what we're going to try to practice as best as possible.
So this doesn't require any long comments, but maybe a brief comment on BIO, lid work, anything where you're touching the patient minimally. To Lori's point, touch a patient, discard a pair of gloves. Do you envision using gloves for those things where you touch the patient in those ways?
Correct.
I see head nods from everybody. Okay. I appreciate that. One more thing. Could those of you who have either practiced on slit lamp, seen family or emergency patients on slit lamp, talk about you wearing a mask? Is it difficult to breathe and talk through the mask? And how are you dealing with your own spectacles and the oculars of your devices, particularly slit lamps and BIOs fogging up? Could you give us a quick hit on that?
I just took a molded shield. You have shields that are replaced on a head mount on a helmet. I just took the molded shield itself, and I took a drill bit for a door, and I drilled 2 holes in it for the opticals. And I needed 13 of them. So I made 13 of them, and they go right on there, and it wraps right around your head. So when you look in there, I'll have my mask on still, but the shield is protecting you. And so that's what we're using.
Okay.
No fogging.
Take a picture of that, Brian. I'd like to see it, because I ordered some shields for the patient side of the slit lamp and the doctor side, and I tried to install them, and whoever designed them didn't know what a Goldman tonometer was, so it doesn't work. You can't really have it on the patient side. So those units were shipped out of Canada, and they're just not working. So I'd like a really good solution to that. But frankly, I feel very comfortable with the N95 mask. I don't think you're going to need, the doctor's probably not going to need a lot more than that. My son is very active in ICU units down in New Orleans right now, and that's what they use. He doesn't wear it.
Are you using one mask for the course of the day? Any of you comment, or are you changing masks frequently?
the N95s can be used over and over and over. And you just
I
need
see everyone nodding to that. Okay.
to-
Jen, you're getting ready. You know, again, I like to talk to you because I think you talk to a lot of people who are on the line here and, you know, not ready tomorrow, not ready even Monday. Are you finding slit lamp barriers easily? I know some companies have provided them. Talk about what you've done to prepare those kind of things for you and your team who use those examining instruments.
So we've ordered those through the companies that are providing those. We've received 2 so far, I believe. I think we've ordered 4. So, you know, I don't envision that we're going to be using all of our exam rooms when we start. We're trying to slowly and surely, you know, procure masks and gloves. We're on the fence about shields currently. You know, that's where I feel like the benefit is I get to watch what everyone's doing and see how people are doing. I saw a question pop up, fogging behind the phoropter. You know, we have not even had a patient in for that. So all of these things, you know, we will be learning as other practitioners go back, since we haven't had that experience. But we're just trying to get as supply as we can and be prepared to that. Right now is, you know, when we go back at the end of May, that, you know, we're assuming that things are going to be like they are today.
Okay, so I've got some quick hitters before we shift to making sure we have our team all set. First, let's talk a little bit, Walt, there's been questions about the air cleaner and the use of medical air filters and such in your AC. Can you just describe what you've got? There's some real interest in what you were describing.
I don't own the building, and right now, I know I'll let Lori speak to what she's done. So I can't really control much about the heating and air conditioning system. There's a company called Medify Air, Medify Air, and they have a number of different sizes of air purifiers. And interestingly, you really think about it, we're really doing a good job not only on their bacteria and viruses, but we're providing a real good environment for our patients during allergy season. Because basically these units are powerful enough to completely clean the office within about an hour of being turned on. So I'm not sure. I thought originally I was going to run these 24/7. I don't think you have to. The filters have to be replaced about every 6 months. But they're HEPA 13 grade filters and charcoal. They have charcoal filter built in, and they do ionization at the same time. So, but
Lori, I know, I'm sorry, go ahead.
Lori, I think.
Yeah, Lori, you had spoken about yours. I don't know if GPN had put out on the iThrive site any links about yours. Obviously, it's an in-furnace system.
It's in the HVAC system, but we also, believe it or not, we also put in the same Medify Air purifiers that Walter is using as well. We're doing both things. And
Okay.
those purify down to 0.1 microns.
Can anybody speak to whether or not they are charging patients for masks that they would provide them?
No.
None. Okay.
You're not going to have to do it. I'll tell you what's happening. There's an awful lot of price gouging going on everywhere. It's really interesting because we're running a little bit low on masks right now, and I found 2 or 3 websites that are charging, you know, $50, $75 for a box of 100 gloves, you know, and masks kind of the same thing. So the N95s we have, we're paying $5 a piece for, but that's $5. That's an expense we didn't have.
Lori, to your comment about no moisturizer, you mean not around the mouth and nose area, and why?
No, I mean on your face if you're going to be reusing your N95. So what we're doing, we have 5 masks each, Dr. Abraham and I, 5 N95s. Actually, we have more than that, but what we're doing is a 5 mask cycle. So on Monday, we wear our Monday mask for the day. And then we are hanging and air drying for 72 hours. So we will not wear, actually longer than 72 hours. We won't wear that mask again for 4 or 5 more days. So we're rotating those. Our scheduled reusage on that schedule is we're gonna do 3 to 4 rotations using that method for now.
So the last thing I can say before we get into the staff issue, and I always tell attendees, you've been at this for a long time. Thanks for sitting in on this, but be mindful. The information that's coming next will be as important as what came out in the first couple innings of this ball game. So stick with us. These experts are doing a great job of informing us. I saw somebody say that they've used some transport tape across the top of their mask to eliminate airflow there, to eliminate fogging of oculars for BIOs and such. The last thing is, are there other pieces of equipment for which we need breath shields, and one was a keratometer. Anybody can speak about other devices for which they've put shield barriers in place? Brian, you're muted.
That might be good.
3, 2,
That might be good.
1. There you
All
go.
right,
Go for it. I saw you saying something important.
Might be good I was muted. I don't know. When we take retinal photos, we're using the California Optos instrument, and we're very close to the individual. So what I did is I found these curtain rods that you can, it's a plastic roll. In fact, yeah, oh, here it is. It's a plastic roll, and you can put it up on your wall. And I got this 15 feet of this for like 20 bucks. And it comes with attachments for your curtains. And I hung up a clear curtain, shower curtain. It costs $8. And we use that as a barrier when they're taking photos. So the patient feels a little bit more comfortable while we're entering data. They can see where the patient's head is, and they can guide them a little bit. The other thing we're doing for pre-testing, I see somebody, I noticed someone question, what do you do for pre-testing? What we're doing is getting a plexiglass that's 48 inches wide by 18 inches high, and we're actually hanging it from the ceiling at just the right height, so when the team member's sitting there, standing or sitting, they have that barrier that's in the way, and that'd be easy to take down when we need to. So.
Okay. Well, then what I'd like to do now is shift to the topic of having the right team to start back with. And I got to go to you first, Jen, because again, you're in the situation where you're probably having to talk to your staff pretty regularly. And what are you thinking about in terms of planning for the right team back? And how are you keeping in touch with your team?
So we have a meeting every Friday afternoon. We do a group call and just kind of touch base with everybody, make sure everybody's feeling healthy and safe. We have 2 staff in the office every day. They work in teams and they keep their same teams, but the door remains locked. I don't even go in. I warn them when I'm coming in, but no patients are to enter the office. So they're there. So we have kind of a huddle to say, how was the week? How's everybody doing? And then, Fader and I, my partner, we update them to say, this is what we know at this point. And, we're honest that we don't have all the answers. We don't have a start date. We know that, we had originally said May 4th. We pushed that back another week. But, I think for us, we're just upfront and honest with them that we don't know exactly what we're going to be doing. We know exactly how things going to look, but we reassure them that we're doing things like this. We're speaking to other doctors, and we're making sure educating ourselves to keep them safe. We might not have all the answers that the other doctors on this call do, but we're just reassuring them that we will be back. We're working on how we're going to schedule that, and that looks different every time we think about it. But I think we're in a different position that we're just making sure that we're continuing to keep everybody together and talking, but we don't have an exact answer every question. The questions come up, the same questions that are coming up on these chats. They ask us, what happens if a patient comes in and does this? And we said, we don't know. We're not in the time frame where we know exactly how everything's going to look. And hopefully by the time we get back, these cases that are continuing to climb decrease. We would not go back right now with the number of cases we have. So we try and put them at ease that we're just not ready at this point.
I've seen some comments from some doctors in the chat around California opening May 11th. Those folks are in the same situation. How many people do you have working today?
Well, my entire staff on, but they're just 2 a day. So we have kept everybody on the schedule 2 a day. But again, the door is locked and they keep their same pairings. And we just, that's part of it is touching base to make sure that everybody's okay. And just, if there's any issue or anyone's not feeling well or has been in contact with anyone not feeling well, we want to know right away.
Brian, Walter, how many people are you having work currently? How are you dealing with that?
Go ahead.
Most of my staff, well, all of our staff right now as furloughed, but I brought back some of the people today or this week for front desk. Next week we'll have most of the staff back at work. But that's where we are.
Okay, Brian.
We furloughed all the doctors except one as of last Monday. With 4 locations, we've kept on the supervisors and typically an optician. In a couple cases, we've kept a technician and a clerical person to help out with phone calls because we are inundated with phone calls. I mean, it's probably the number one issue we've had. But also we need management going on. We need check-in glasses. We still have glasses that are checked in. Our patients want to pick them up, make sure contact lenses are getting on order. And then on top of it, we're getting ready to reopen. So presently, as of next week, we're planning on bringing back some of the team members so we can slowly start to reopen and see more. We've been seeing patients all the way throughout this, but just as an essential basis. And it's challenging. It wasn't easy to put people on furlough last week, and I'm sure all of us are in that same boat. None of us wanted to go there, but you have to survive. And, you know, our team was very gracious and understanding. We hung in there with them for basically 5.5 weeks, paying them full pay, working 15, 20 hours a week. So they've been very thankful and understanding, but it's hard for all of us. And I think it's going to get better, and it will. I mean, for us, next week, we're going to start seeing patients and bringing some people back to the team. We're very excited about that.
Lorie, why don't you start the topic of managing staff return to work? First, for those who come in, are you doing things like temperature checks and wellness checks? And also, let's get into the group discussion after that on those who may not want to return to work, on their decision, right? Because unemployment is you know, being paid, whatever. But first, how are you bringing people back? And then how are we dealing with those who may not want to come back?
I think that's a great question. So my biggest advice after, you know, like Brian said, remaining open, seeing patients, and now going and expanding the type of care we're providing. The biggest thing that I can say is have a written plan. The plan isn't necessarily for you, but I'm telling you, it really calms the staff and it shows them that you've put a lot of thought and a lot of care into safety measures and workflow. Think through workflows. And then as you start bringing staff back, your plan is really going to guide you. Your plan is really going to be your fallback, and your plan's going to change. Ours has changed probably 8 times since we first initiated our plan. But every day does get better. Every day has gotten better. The more everyone's on the same plan, the easier it goes. But we are seeing patients with less staff than I've ever seen patients with. 4 people. We have an optician, a front desk, a tech, and sort of our office supervisor, manager, if you will, that does the billing as well. Our phones, like Brian said, are our biggest problem with that staff. We're managing patients, but the phone, you know, when we're working with patients and the phone keeps going, that's an issue.
Okay, so how about anybody else? Anybody else doing anything to bring people back under certain controls, like temperature checks, wellness checks, you know, anything at all that anybody's got to offer on that topic?
We're doing pretty much the same as Lorie. We're going to be doing pulse oximetry because that helps measure pulmonary function issues. We're also doing infrared temperature checks. So those 2 things will be there. And we've got a COVID-19 checklist, actually, that we're using the same one that Lorie's going to be using. To the point of furlough staff coming back, most of our staff has been extremely supportive and very grateful for the things we've tried to do. And we went through about 3 payroll periods where we were paying the staff, but they were also burning vacation and paid leave at the same time. So they were required to do that. But we've got a couple of staff that are making the same or slightly more with this federal unemployment check than they were at our office. And they're not quite as excited about coming back because that could actually continue until July the 31st. So I don't think it's going to end up being an issue because we've made it clear that we're going to be open. So I think that they'll be on board.
I'd like to ask, go ahead, is that Brian?
Brian, I think the question had come up to Brian, and I think, have you increased the pay for some of your people coming back? Or?
One of the things I would have you consider is a bonusing system. You could actually bonus if you want them to come back. Right now is a perfect time to really weed out your team. As Lori was indicating, she was surprised she's able to do all these exams and treating patients with 4 people. She hasn't done that in a long time. And we're doing the same thing, and it makes us think, boy, maybe we should do cross-training more. Maybe we could be a lot more efficient with our time. And let's get the really good people here working a little bit more and interactive with our patients and our team, rather than having a couple people that are hired. I'm sure that low-hanging fruit, and I hate to say that about people, but there are team members sometimes maybe you could do better without. And it's a hard decision to make, but we might need to do that. And they might be doing us a favor by being on unemployment, not wanting to come back. But if there are those that you do want to have come back, and it is a challenge, you would have to bonus across the board, though, is what we would do, is we do a bonus across the board. And most of us give a bonus at the end of the year. So why wait? Why don't we give the bonus early? And that gives them an incentive to get back to the table, possibly. Just a thought.
I'd like to, we are going to promise everyone an hour, so we're running low on time. So I want to ask Jen and Lori first to talk about this topic. There are some ECPs who are pretty unhappy and miserable and feeling very lonely right now. What are you doing to keep yourself positive? That's so important from a leadership perspective, right?
You're talking about Disney.
Yeah. So get on a call with some other Disney fans. That automatically brightens your mood. But, I've been reaching out, and I've had a number of study group conversations with other doctors. We've set up Zoom calls. I was on 2 yesterday with colleagues throughout the country just doing this. We got together and said, what are you doing? When are you opening? How are you, the questions that have come up here, just getting together, and instead of doing it over email, seeing people's faces and just chatting. And we've done, with IDOC, I've done 2 virtual study groups with my local doctors, and I look forward to it. And I look forward to seeing their faces and just hearing how they are. And that's a question we ask on our calls too. What are you doing to keep yourself sane? So, getting outside. It's beautiful here today in Connecticut. So as soon as we're done, I'm going outside. But just reaching out to colleagues, because it's nice to know you're not alone, and every single person in the country is going through the same thing. And especially as we start to head back to your colleagues who are going back, and, touch base and see how they're doing, how are they feeling, what have they learned, and just being supportive. But I think doing it on Zoom, or doing it, so you can see people's faces, is so great.
Lori?
Yeah, everyone that knows me well knows I'm an avid walker. I walk 8 miles every day, so that keeps me sane, and I do a lot of thinking while I'm walking. But I will say, Jen, you hit the nail on the head. We have a 6:30 happy hour group, all ODs, that meet together at least 3 times a week, and we talk. We can go 2 hours. We talk. You guys probably are listening, so you know who you are, but we talk everything optometry, everything that we talked about today. And we've been doing that since it started. That has helped me tremendously. That peer support, professional support, and really it's energized me in a way that I never thought possible.
Walter, one quick question came in. A lot of people are talking about things that cost a lot at a time where we don't have revenue. We just had Mick Kling on last week talking about financials, and I'd make sure everyone goes and watches the recording of that webinar, because Mick really did a great job. You're a very astute business person running a large practice. You got to make a lot of decisions right now, I assume. Are you thinking about not just the staffing topics Brian talked about, maybe there's people you don't bring back, but also how you cut other expenses, how you think about vision plan participation? Any quick tidbits on that?
We're looking at everything. I mean, we're taking the time now, because we haven't been seeing patients, to look at lab bills, to look at every single line item that we possibly can. And I think we're going to have to remain viable. I mean, that's just the bottom line. And, the message I've given my staff basically is that the overwhelming majority of healthcare facilities around the country are laying off people permanently. And if they're not, they're reducing their salary 15 to 25% to stay viable. And those are just economic realities. One positive thing that will come out of this for business owners, optometry and ophthalmology practice owners, is the fact that we're all of a sudden going to have a labor market that's it's much better for us. So to Brian's point, it gives you an opportunity to take a look at the staff you've got, reassess, realign. As a matter of fact, I had a young lady who's a certified ophthalmic assistant, and I like to hire COAs and COTs because of their polish and dealing with patients in a surgical environment. And I hired a new COA Friday. She's sharp, she's moving to town and ready to go to work.
For all of you who have attended, we're so grateful you spent the time listening to this panel of experts give us such important insights. And I can't thank all of you enough. The GPN Technologies Next Steps webinar continues next week, a week from today, on the topic of dispensary management amid social distancing, which we kind of hit on, and there were a lot of questions about today. So that's the next one. Until then, I can't thank Jen and Walter and Brian and Lori enough for your expertise. Thank you so much for giving of yourselves this way.
Thank you.
You're welcome.
All right. Until then, everybody, thanks for attending. On behalf of GPN Technologies, we appreciate that you sat with us. Send in your other questions. We'll try to answer them. And in the meantime, be great at everything you do. Goodbye for now.
Great job, Scott. Thanks.
Thank you.